Welcome to the deep dive, where we cut through the noise and get straight to what matters. Imagine this a medical emergency so intense, so critical, that doctors literally say time is brain.
Yeah, it's a powerful phrase.
We're talking about status epilepticus, SE. It's when a seizure just keeps going, longer than 5 minutes, or, the person keeps having seizures without fully recovering in between.
And that clock is absolutely ticking. Because if that seizure activity goes on for, say, past 30 minutes or so, it can start causing permanent damage to neurons. Real damage.
It's not just about stopping the shaking you can see, is it? It's about protecting the brain itself.
Precisely. It's incredibly urgent. And that time is brain idea really hits home the stakes. Prolonged seizures can lead to, well, irreversible damage, developing chronic epilepsy later, significant long-term thinking and memory problems.
Wow.
And what's really sobering sometimes is that the average time from when a seizure starts to when someone actually gets to the hospital can be around 34 minutes.
34 minutes. So often.
Often, they've already crossed that critical 30-minute threshold where irreversible harm might start, even before they get definitive hospital care.
That's a stark reality. And it absolutely sets the stage for our deep dive today. We've pulled together a whole stack of fresh expert insights for you.
Good stuff.
Yeah, the latest medical guidelines, some really in-depth discussions from places like EM-CRIT, crucial details from big trials like ESET, some groundbreaking findings from the ketamine study on kids with SE, and comprehensive guidance on managing those really tough refractory seizures.
So the really stubborn ones.
Exactly. Our mission here is simple. Cut through all that information overload and give you the most important, sometimes surprising takeaways so you can understand how this life-threatening condition is being tackled right now.
Okay, so let's start at the beginning. Someone's in status epilepticus. What's the absolute first move? The immediate frontline attack.
Right, those urgent first steps. Well, the established go-to, the first line of defense for convulsive SE, it's still benzodiazepines, the benzos.
Yep. Nothing's really replaced them for that immediate intervention. They
Yeah.
are absolutely critical.
So which ones specifically, and how are they used?
Well, for adults, a really common approach is levetiracetam, given intravenously if possible. It's often preferred because it tends to stick around in the brain a bit longer than some others.
Okay.
The dosing is usually weight-based, maybe zero 0.1 milligrams per kilogram, often capped at, say, 8 milligrams total. That's kind of the backbone dose from big studies like the VA Cooperative RCT.
That set the standard.
It really did. Although it's interesting, one expert we looked at, Scott, sometimes uses a smaller initial dose, maybe 2 milligrams, if the seizure's only just started, like less than 5 minutes.
Okay, but what if you can't get an IV right away? I mean, that happens a lot outside the hospital, right?
Well,
In
yeah.
chaos.
That's a huge point, a
Mhm.
crucial one. If you can't get that IV line in quickly, midazolam becomes the drug of choice, specifically given intramuscularly into the muscle.
The IM route.
Exactly. The Rampart study really showed how effective a 10 milligram shot of midazolam IM can be. It works remarkably well.
10 milligrams IM. Got it.
Now, if you do have IV access, the dose is typically smaller, maybe 5 milligrams IV, and you can repeat that after a couple of minutes if needed.
Okay.
And, if the seizure's been going on for a while, say over 10 minutes, or if EMS was already managing it before they got to the hospital, then a 10 milligram dose of midazolam, either IV or IM, is pretty common if it hasn't been given already.
What about diazepam? Valium. That's a name lots of people know. Is that still in the mix?
It can be used, yeah,
Yep.
if the other options aren't available. The typical IV dose is around 10 milligrams, repeatable every 5-10 minutes, maybe up to 30 milligrams total.
But, sounds like there's a but.
Yeah, there is. It's generally less preferred. And the reason is diazepam gets into the brain really fast, but then it leaves the brain really fast, too. It redistributes into body fat.
So the effect wears off quickly.
Exactly. You might see the seizure stop, but then it can come back maybe 30 minutes later as the drug leaves the brain. So it's kind of a short-term fix, which isn't ideal for SE.
You mentioned something earlier about adequate dosing up front. That feels really important, especially with benzos where there's this fear of giving too much, causing breathing problems. Why hit it hard early? And does it actually cause more issues?
That is such a key question. And it really gets at a common misconception. For a long time, the thinking was, oh, these drugs will cause respiratory depression, lead straight to intubation.
Right.
But what's fascinating and kind of surprising is the evidence points the other way. Giving an adequate dose right at the start might actually reduce the need for intubation later.
Really? How does that work?
Well, think about the brain during a long seizure.
Mhm.
Those GABA receptors, The brain's off switches that benzos target, they
Mm.
actually start to retreat. They get pulled inside the neuron.
And I
Internalize.
become less available.
It's
Yeah.
exactly less available, less sensitive to the drug. So if you underdose early on, you're kind of missing your best shot when the receptors are most responsive. You need enough drug there before they disappear.
That makes sense. And the breathing issue.
The reality is clinicians need to be patient. After a seizure stops, the person might be groggy, altered. That's postictal state. That itself isn't a reason to intubate. The bigger danger often is the ongoing seizure activity itself, not necessarily the appropriate dose of the benzo needed to stop it.
Okay, that's a really important distinction. So let's say the benzo works, the seizure stops. Great. Are we done? Is the patient safe?
Definitely not out of the woods yet. Far from it. Even if you stop the immediate convulsions, you absolutely have to give a loading dose of a maintenance anti-seizure medication right away.
To prevent it from coming back.
Precisely. Prevent recurrence. And this ties into another really crucial step, kind of an aha moment sometimes. Immediately check for critical reversible causes. Simple stuff. Fingerstick glucose. Is their blood sugar dangerously low? If so, giving D50W, concentrated sugar water, can literally be life-saving, stops the seizure right there.
Wow.
Or checking sodium levels. Really low sodium, hyponatremia. That needs specific treatment, like hypertonic saline. And sometimes, especially in patients with a history of heavy alcohol use, you might give IV thiamine empirically, just in case it's thiamine deficiency.
So quick checks that could reveal the actual root cause.
Exactly. It can be a rapid turnaround if you find one of these.
This all just keeps reinforcing that time is brain idea, doesn't it?
Yeah.
How much does delaying seizure control really impact things long term?
It's absolutely paramount. The longer SE goes on, the harder it becomes to treat. It gets more resistant. And this leads directly to progressive brain damage, a higher risk of dying, developing chronic epilepsy down the road, and, lasting cognitive problems.
Yeah.
Like we said, if someone's seizing for 34 minutes before they even get to the ED door, they've potentially already entered that zone of irreversible damage. Every single minute counts in stopping that cascade.
Okay. So what happens when the benzos, despite being the first line, just don't work? Because we know that happens sometimes. That must be terrifying.
It is. It's a really significant challenge. You see, maybe up to 40% of generalized convulsive SE cases in kids aren't stopped by that first benzo dose.
40%. Wow.
Yeah. And for adults, maybe more than a quarter of patients having seizures outside the hospital keep seizing even after getting what should be enough benzodiazepines.
So you desperately need a good second option.
You absolutely need a readily available, effective second-line treatment. It's critical.
And this is where it gets really interesting, right? The emergence of ketamine. Why ketamine? What makes it different? How does it work when the benzos are failing?
Ketamine is fascinating because its mechanism is just fundamentally different. Think about that seizing brain again. We said the GABA receptors, the off switches that benzos hit, they start to downregulate, they disappear.
Right, making benzos less effective.
Exactly.
Mm.
But at the same time, the brain's on switches, the excitatory NMDA receptors, they actually become more active, more upregulated.
So the brain is stuck in on mode.
Pretty much.
Yeah.
Right. Ketamine doesn't work on GABA. It's an NMDA receptor blocker. It targets those overactive on switches.
Ah, so it's hitting the other side of the problem.
Precisely. It's a different pathway. So you get this potential synergy. Benzos are trying to boost the off signal. Ketamine is trying to block the on signal. This dual approach might explain why it seems particularly effective in these prolonged benzo-resistant seizures.
And what about its safety profile in these really sick patients?
That's another attractive feature. Ketamine often has some real advantages in emergencies. It can actually be neuroprotective. It tends to maintain blood pressure or even give it a little boost, which is great because many other sedatives can drop blood pressure.
That's a big deal.
Huge deal. And crucially, it generally preserves the patient's drive to breathe and their airway reflexes much better than some alternatives. Now, if you push it super fast, you might get a brief pause in breathing, brief apnea, but generally it's pretty good on the respiratory front. Plus, it relaxes airways to bronchodilator.
So overall, a pretty compelling package for an emergency.
It really is. Makes it a very attractive option when time is critical.
I've heard some experts, like the folks discussing on EM-CRIT, are already bringing ketamine in really early. What's that tell us?
Yeah, it shows how practice can evolve pretty quickly when compelling data starts to emerge. For instance, Scott, one of the experts, talks about using ketamine, maybe 1 milligram per kilogram, right along with a second dose of midazolam.
Wow, that early.
or even right after the first 10 milligram dose if the seizure's already been going on for a while. It's a proactive approach, trying to hit the seizure with multiple mechanisms sooner rather than later.
And is there solid evidence supporting this kind of use, like from actual studies?
Yeah, there's some really interesting data coming out. Take the Shepke study, for example. This was done in the pre-hospital setting, looking at paramedics.
Okay, out in the field.
Right, it was a 7-year observational study. They looked at what happened when paramedics gave ketamine to patients whose seizures weren't stopping with midazolam.
What did they find?
The results were pretty striking. In adults, ketamine stopped the convulsions rapidly in almost every single case, 98.2%. That was 56 out of 57 patients. And crucially, the seizures didn't restart during transport or on arrival.
Incredible. What about kids?
Similar results in children and adolescents. Rapid sustained seizure stoppage in 11 out of 15 cases.
What kind of doses were they using out there, and was it safe? That's always the concern.
Good question. For adults and teens, it was typically 100 milligrams, and they could give it IV, IM, IO into the bone, or even intranasally. For younger kids, it was weight-based, 1 milligram per kilogram, usually IM or IN.
And safety.
A study reported no major complications directly blamed on the ketamine. Importantly, there wasn't an increased need for breathing support or intubation after the ketamine was given. Vital signs generally stayed stable.
That sounds incredibly promising. Any catches? Any caveats we need to know?
Yeah, a couple of important ones. While it clearly stopped the physical shaking, the motor activity, the study couldn't confirm if the underlying electrical seizure in the brain, the electrographic seizure, had also stopped. That needs EEG monitoring, which they didn't have in the field.
Okay, fair point.
And also, specifically for children, the intranasal route didn't always work as quickly or reliably. So maybe that route has some limitations, particularly for kids in SE.
Okay, now let's dive even deeper into the pediatric side. You mentioned the ketamine study. That sounds like a big one, a randomized controlled trial. What did that show?
Oh, this study was potentially a real game changer. It involved 144 kids from 6 months up to 16 years old, all with generalized convulsive SE.
Okay.
They directly compared giving a combination of ketamine, 2 milligrams per kilogram, plus midazolam, 0.2 milligrams per kilogram, versus giving just midazolam alone with a placebo added so nobody knew who got
A
what.
gold standard comparison.
Uh,
And the results.
Honestly, they were stunning. Clinical seizures stopped within 5 minutes in 76% of the kids who got both ketamine and midazolam,
76% compared to...
compared to only 21% in the group that got midazolam alone.
Wow, that's a massive difference, a nearly four-fold increase.
Huge difference. Huge. And the benefits didn't stop there.
Tell me more.
The ketamine group also had significantly higher rates of seizure, stopping at 15 minutes, 35 minutes, and 55 minutes. They needed way fewer repeat doses of midazolam. Only about 24% needed more, compared to almost 80% in the midazolam-only group.
Less rescue medication needed.
Exactly. And maybe one of the most compelling findings, especially for parents and clinicians worried about critical interventions,
Yeah.
the rate of endotracheal intubation was dramatically lower.
How much lower?
Just 4.2% in the ketamine group needed intubation versus 20.8% in the midazolam alone group.
That's a five-fold reduction. That's incredible and speaks volumes about safety too, doesn't it?
Absolutely. There were no significant differences in other bad outcomes like low blood pressure, heart rhythm issues, scary emergence reactions from the ketamine, or death. So, if anything, that much lower intubation rate points towards a safer overall profile for the combination.
Any specific group of kids where this combo really shone?
Yes, and this connects right back to that time as brain idea. The study found that adding ketamine was significantly more effective in stopping seizures in those kids whose seizures had already been going on for longer than 30 minutes before they even got to the hospital.
So it's particularly powerful for those really prolonged, high-risk cases.
Exactly, which could be truly transformative for managing those incredibly difficult situations.
Okay, so ketamine looks really promising for stopping the immediate fire, especially the stubborn ones. But even once the seizure stops, the brain needs ongoing protection, right? To prevent it from just starting up again. What's the next layer of defense?
Precisely. Stopping the active seizure is step 1, but preventing recurrence is step 2, and it's just as vital. That means getting a loading dose of a maintenance anti-seizure medication on board quickly.
A maintenance drug.
Yeah, but it's important to remember, if the patient is still actively seizing and clearly needs to be intubated, you don't delay intubation waiting for these maintenance drugs to infuse and work. Airway comes first in that scenario.
Got it. So, among these maintenance drugs, what's the usual go-to? I hear levetiracetam or Keppra mentioned a lot.
Yes, the levetiracetam is very frequently the first choice for maintenance loading. And there are good reasons why.
Like what?
Primarily, its excellent safety profile and just how convenient it is. The loading dose is pretty standard, around 60 milligrams per kilogram, up to a max of 4.5 grams, and you can give it fairly quickly.
And the evidence supports it.
Yeah, the big ESET trial directly compared levetiracetam against fosphenytoin and valproate for seizures that didn't respond to benzos. It found all three were similarly effective. They stopped the seizure and improved alertness in about half the patients by 60 minutes. Adverse events were similar too.
So, not necessarily better than the others in ESET?
Not clearly superior in terms of raw efficacy in that trial, no.
Yeah.
But its big advantages are. It has virtually no major contraindications, very few drug interactions to worry about. It doesn't really cloud consciousness further, and you can give it fast. It's just easy and safe, especially when you don't know the patient's full history.
Makes sense. Reliable and safe is good in an emergency. What if levetiracetam isn't chosen, or maybe a second maintenance drug is needed? What's a strong alternative?
Lacosamide, brand name Vimpat, is another excellent option. It works differently. It's a sodium channel blocker, kind of like phenytoin, but often with a better side effect profile.
Okay. How's that given?
Typically a 400 milligram IV load given over about 5 minutes, maybe a bit slower in some cases.
Any major red flags or contraindications for lacosamide?
Yes, definitely. You need to be cautious or avoid it in patients with pre-existing heart block or significant conduction system disease. Because it's a sodium channel blocker, it can affect heart rhythm, although serious issues are rare. Also, caution in severe liver disease.
Good to know. But otherwise, a solid choice.
Generally, yes.
Yeah.
Good safety profile, not many drug interactions, reliable effects.
Are there other key players in this maintenance arsenal, maybe for specific situations?
Oh yeah, valproic acid, phenobarbital, and fosphenytoin are definitely still important tools in the toolbox.
Okay.
One key interaction to know. You generally don't want to give valproic acid and fosphenytoin together if you can avoid it. Lots of potential interactions there.
Good tip.
And each of these has its own niche, Valproic can be great for certain seizure types like myoclonic seizures or even sometimes used in agitated delirium. Phenobarbital is often the preferred agent for seizures related to alcohol withdrawal. Fosphenytoin is a classic, long-used option.
So a range of options depending on the clinical picture.
That's exactly.
Okay. So you've thrown the kitchen sink at it, benzos, maybe ketamine, loaded maintenance drugs. But what if, despite everything, the seizures just keep going? What's the next more aggressive step when things are truly refractory?
Yeah, that's when you enter the territory of refractory or even super refractory status epilepticus. And at this point, there's a very, very low threshold for intubation and starting general anesthesia.
Neurolytic intubation, basically sedating and paralyzing to take control.
Right. If seizures persist despite those initial rounds of treatment, securing the airway and inducing anesthesia becomes critical to stop the ongoing brain injury.
What drugs are typically used for that induction, specifically aiming to stop seizures?
Propofol is often considered the best choice here, not just because it sedates, but because propofol itself has pretty potent anti-epileptic properties.
Ah, so it does double duty.
Exactly. Ketamine can also be used here, sometimes synergistically with propofol or maybe midazolam. Remember, its NMDA blockade complements the GABA effects of the others.
Yeah.
So a strategy some experts use might be, say, pushing 200 milligrams of IV ketamine, then maybe 100 milligrams of propofol, followed by a muscle relaxant like rocuronium to facilitate intubation.
And the paralytic, the muscle relaxant, does that stop the seizure?
Crucial point. No. Paralytics like rocuronium or succinylcholine stop the muscle movements, the convulsions you see, but they do absolutely nothing to stop the electrical storm happening in the brain.
So it can mask an ongoing seizure.
It can completely mask it. The goal is always stopping the brain's seizure activity, not just making the patient lie still. Paralysis doesn't prevent brain damage if the electrographic seizure continues.
Got it. And inducing anesthesia with drugs like propofol often means watching blood pressure closely, right?
Absolutely critical.
Yeah.
Propofol is a vasodilator. It can definitely cause hypotension, low blood pressure. You need to be ready for that. Have a vasopressor infusion like norepinephrine, primed and ready to go immediately after intubation to support their hemodynamics.
Okay, so the patient is intubated. How do you manage the ongoing anesthesia to really crush those seizures?
For ongoing control, the experts we reviewed often rely on propofol again, but as a continuous infusion. And usually at higher doses than you'd use just for sedation, maybe 80 to 100 micrograms per kilogram per minute, or even more. The goal is often burst suppression on the EEG, really quieting the brain activity down.
And that works.
It's often very effective for rapid seizure control,
Yeah.
and a benefit of propofol is that it wears off relatively quickly, so you can often wake the patient up and extubate them within maybe 24 hours once things are stable.
What if propofol isn't enough, or you need longer-term anesthesia?
Well, one expert mentioned possibly switching to a high-dose midazolam infusion if seizures are still ongoing after, say, 48 hours on propofol. But midazolam infusions have downsides. Patients can become resistant, and it takes a long time to wear off, delaying waking up and extubation.
Any other options for continuous anesthesia?
Ketamine can also be used as a continuous infusion, maybe 1 to 7.5 milligrams per kilogram per hour.
Mm.
It's particularly considered in super refractory SE, partly because it's generally more hemodynamically stable than propofol or barbiturates.
And the last resort.
That's usually considered the pentobarbital coma, inducing a deep coma with pentobarbital. It's very effective at stopping seizures, but it comes with significant downsides. A very long half-life, meaning prolonged ventilation, often severe hypotension requiring lots of pressor support. It's really reserved for when almost everything else has failed.
Wow, that's heavy stuff. And throughout all this, especially when the patient is paralyzed, how do you know if the seizures are truly controlled?
That's where continuous EEG monitoring becomes absolutely essential. Mandatory, really, in the ICU for managing refractory and super refractory SE.
Because you can't see the seizure anymore.
Exactly.
Yeah.
The clinical signs might be gone because of the paralytics, or the seizure might just be subtle, non-convulsive. You need to see the brain's electrical activity on the EEG to confirm that the seizures have actually stopped electrographically and aren't just continuing silently, still damaging the brain.
So as we wrap up this really intensive deep dive into status epilepticus, what are the absolute key takeaways, the things you really want listeners to carry with them?
I think there are a few really striking insights. First, just reinforcing the profound importance of time as brain. Every single minute genuinely impacts long-term outcomes. That urgency can't be overstated.
Right.
Second, the surprising efficacy and, importantly, the safety profile we're seeing with ketamine as an early second-line agent, especially in kids. And in those prolonged seizures, it offers a powerful alternative when the traditional approach falls short. That's a major shift.
Definitely.
And finally, just appreciating the robust but also adaptable arsenal we have. From the initial benzos to maintenance drugs like levetiracetam or lacosamide, all the way to sophisticated anesthetic strategies. Clinicians have tools to tackle even the most stubborn cases, but it requires continuous assessment and adjustment.
This whole conversation makes me wonder, as we learn even more about this complex dance of brain receptors during prolonged seizures, the GABA downregulation, the NMDA upregulation, how might future guidelines evolve? Could we see a push towards more aggressive multi-mechanism combination therapies like that ketamine approach, maybe even earlier in the process?
It's a fascinating thought.
Could it fundamentally change what we even call first-line treatment, pushing us towards an even faster, more comprehensive initial attack? And what does this deeper understanding of SE mean for your perspective on how we should approach rapid response in any medical emergency?